last week we were tackling a topic known as trying to cope up with the stress in this COVID-19. Many people are stressed up, families are breaking, there's a lot of rebellion from children, and now the people are losing their jobs. There's a lot of stress going around, and we're trying to help people. How do they manage the stress, most in this COVID-19? How do they come out of it victoriously, just to be pampered by what is happening around, and then we lose it all. And so today we're going to have another exciting and interesting study once again. And I just want to welcome all of you for it. And our title for today's interesting study is about demystifying mental health. I understand there's so many myths that have been talked about mental health. And today, with our expertise, we want to understand, what does it mean to have mental health? What is it associated with? Is there anything that people have been speaking about that is not right with mental health? And apparently, some of us are not in the field of mental health. We've been taking it like it's the right thing, yet it's not the right thing. So today we want to learn more. And today on the panelist is Anne Munyao. You're welcome so much. Thank you so much for making it today. And Mrs. Makau, I want to welcome you sincerely to be part of this. Thank you so much, and let it roll. Back to you, Aflin Taffy.
All right, Ruth has said it all, so I'm just going to welcome, just a slight correction, Dr. Makau, Mrs. No.
All right.
Okay, all right.
Dr. Makau.
Okay, so I'll just take it back to Ruth. This is usually an engaging session where we get to share one-on-one, and also at times you always have sessions to just support each other. But today we're going to be learning about the myths, and Ruth has said it all. So I'll just take it back to you, Anne, so that you do your introduction so that we know you well, and then also you can allow Dr. Makau to do the same. You're welcome.
Thank you, Taffy. Good afternoon, everyone.
Good afternoon.
Thank you. It's an honor to be here today. My name is Anne Munyao. I'm a counseling psychologist. So, Ruth, I'm not a doctor. I haven't trained together. I think we interchanged our titles. I'm Mrs. Anne Munyao, and I know Dr. Priscilla Makau, so that's a difference, but it's okay. So for me, it's an honor to be here today. And for me, I'm very passionate about mental health, appreciating our wellness, appreciating what makes us wake up every day and go do something productive. So for me, I feel honored to be part of this forum. And without much ado, I would want to get to introducing the Daktari, but I'll let her do the introduction herself. But it's good to mention, today we are talking about demystifying mental health, and let's dispel the myths around mental health. There are a lot of myths around it. We believe in different things, we look at it differently. And even as I start off, I would want to ask our people, the members in this team, what comes to mind when you think or hear about mental health? You can write it in the charts. What comes to your mind first? Could be short answers of what it is that you hear when someone talks about mental health. And then also, the myths we talk about, they come as a result, and then they cause misunderstandings. We stereotype our attitudes surrounding mental health. All those become part of the problem. And we end up in judgments, discrimination, stigmatization, labeling, and isolating people who we believe have mental illnesses, as well as their families. So without much ado, I would want to invite Dr. Priscilla, tafadhali, join us, tell us about yourself, introduce yourself. Let's hear it from you. But it's an honor to have you here. I can imagine you've taken time off your busy schedules, but karibu sana.
All right. Good evening, all.
Good evening.
I don't know if I'm the one who's hanging or hear me.
Yeah, we can get you.
So yeah, my name is Dr. Priscilla Makau, hapo kwa Mrs. I hope most of us understand Swahili, because I have this beautiful tendency of switching between the two. Yeah.
I can't understand.
Yeah. The Mrs. part is the. You can't understand. Don't worry. There'll be very few Swahili words.
I think,
My name is
Dr. There is one member who is from Uganda and it doesn't understand Swahili.
Yes, I got that.
Yes, thank you. All right.
Yes. So, as I was saying, that's my name. I'm a resident at the Mathare Teaching and National Referral Hospital. I'm doing my psychiatry master's there. And yes, I'm part of the mental health task force, and I love mental health. That's why I'm doing it. So we will go through the issues today, and then in case of any questions, feel free to ask. And I would really like to hear, to read some of the answers that you're giving for what comes to mind when you really hear the mental health. What does that mean to you? And then maybe we can define it correctly. Yeah, because now maybe what you're saying is a myth, right? And then we can learn more from each other. Thank you.
Thank you, Daktari. So we'll go to what people are saying about the myths. And the first one is wazimu. People think of wazimu when they hear. For the benefit of the Ugandan, one of us from Uganda, wazimu means mentally unstable, like madness. That's what it means. Someone else thinks of untidiness and violence. That person, Yasmin, thinks witchcraft. Tabitha thinks a state of being psychologically unwell. So even as we listen to what members think about when they hear the word mental illness, I think Daktari is for you to demystify for us the myth, and also to tell us more about what makes us predisposed to mental illness or what it is. Is it an African thing? Is it a Western world disease? So help us dispel those myths. And of course, as we go on, we'll be talking about the minimal myths. Like now you can see someone thinks of madness, untidiness, witchcraft, and so many other things we think about. Asante.
So there's mental illness, mental health, and mental well-being, right? So those are like three different things, because mental health is like saying physical health, right? So what is mental health basically? It's a state of well-being where as an individual, you're able to realize your own abilities, you're able to cope with the normal stresses of life that happen in life as you live, you're able to be productive in your society and be fruitful and be able to give back to your society. Now, when you have that, that's what we are saying, it's mental health. It's a state of that. When you're able to, it's a state of well-being where you are as a person able to realize that, okay? That's what mental health is, all right? Then there's the mental well-being, which is an active process of the mental health part. And then now there's the mental illness and the mental disabilities or the mental conditions, which now becomes the disease aspect. I hope you're getting. So mental health on its own is not the disease. So that is myth. Myth one. Yeah, I'm done with that, right? So you have mental health is a state of well-being for yourself. Yeah, you're able to realize your own individual. You're able to be productive. You're able to cope with your normal day-to-day stresses of life. All right. And then for it to become a disorder, you will be unable now to cope with your day-to-day life stresses. You'll be unable to be productive in your community. And then in that community where you're in your culture, it will be different. I usually say, this is my own type of example, where in Africa today, when of course post-COVID or pre-COVID, you would walk on the beaches of Mombasa and you'd be walking clothed. You know, you'd have a swimming costume on or a bikini, you know, for those ones who love bikinis, or you'd have some t-shirt, you'd have an outfit on covering your body. That is how our culture is in Africa, in Mombasa, okay? But I hear some parts of the world where they have nude beaches. So if you walk nude at those beaches, guess what? You're not going to be termed as someone with mental illness, because the cultural aspect when you're saying somebody has a mental illness. I hope you're able to incorporate that. Okay, so that's one of the definitions of mental health, mental well-being, mental illnesses. Some other myths that we come across is that mental health issues are uncommon. Lies. What is uncommon per se is the psychotic part, the percentage of people who will be walking around, running, you know, the wazimu quote unquote that you keep on seeing around. Actually, that is a very small proportion of the mental illnesses and the disorders that we have in the mental health illnesses spectrum. All right? They are common. We have different types of mental health diseases or conditions, ranging from depression, which are the mood disorders. So you have depression, you have the bipolar, you know, you have childhood disorders, the ADHD, which is attention deficit hyperactivity disorder. You have the autism spectrum disorders, which happens in the childhood. You have the personality disorders, where they are changed from one person to another depending on how they've been. The diseases that have been there in the human being for a while. So there are different types of mental illnesses, and they are there. It's just that the ones that people put out there, the chronic ones, and the ones that are termed as wazimu, the psychotic one, just make 1% of the broader spectrum of the diseases that we have. Okay? Also, another thing, there was a study that was saying that 1 out of 4 people that are walking around this world are suffering or will suffer from a mental illness in the course of their life. So it's not uncommon, it's actually there. All right? Another myth is that many people who are suffering from mental illness are violent. That's not true. As you said, mental illnesses are common. It's just that we only know the very few, the 1%. So most of them are okay. They are normal people who go to work. They are people who follow the rules. It's just that the small percentage that you know seem to look like they are violent. And there was a study that was done in the state that actually showed that less than 5%, less than 5 of the people who are committed some crimes, some forms of assault, were actually suffering from a mental illness. Then another thing is people who are mentally ill cannot have jobs. They cannot be employed. They cannot have careers. That's not true, because people who have mental illness, as you said, because it's a common thing and it's broad spectrum, you can actually be going to work. You can function. And you will be able to move from that. You recover and you're able to work. So people who have mental illnesses actually do hold jobs. They have careers, and it can be anyone. It can come to either you, me, and we move on from that. Another thing is, maybe you're getting a mental illness because you're a weak person, you have a weak personality. No. Anyone. I think for me, that's the beauty of mental illness. You are not immune. No one is immune to getting a mental illness. Anyone can be affected. Anyone can get a mental illness. It's not because you're weak. It's just how you deal with the stresses of life, how you cope. There's something called the biopsychosocial model, where we are saying you, the person, is the biological being. There are some risks that you are having innate, okay, that you're born with. Maybe in your family, you have someone who has a mental illness. Some illnesses have a higher chance, like the mood disorders. If you have maybe a parent who has a mental illness, then around 25 to 50% chance, you have a chance of getting the mental illness. But if you are in an environment that supports you, then you might not get the mental illness, which is now the area that you're in. Okay, So there are very many different reasons as to why someone develops a mental illness. All right, they are not weak. Another thing is that if someone has a mental illness, you have to shun them away. You cannot be their friend. You know, if it's your relative, you lock them up. No. People who are suffering from mental illnesses need our love and our support. So when you come together, because it's part of the management of mental illnesses, is emotional support, psychological support, social support. And we are social beings. So you just bring them together, talk to them, be empathetic. You know, the language that you're using when talking to them, you should not be telling these people who have mental illness that, you cannot amount to anything because you have a mental illness. Already, you're stigmatizing and discriminating the person. And you're forgetting that tomorrow it could be you. Okay? Because you said anyone can get it. You said 1 in 4 people in the course of their lifetime can get a mental illness. So you should love them. You should understand them. Use supportive language to help them. The same way someone has a physical or a medical condition, for example, diabetes. When you hear someone is diabetic, you want to tell them, make sure you take your medication, you're good to go. The same thing with someone suffering from a mental illness. Another thing is you will notice that most of our mental illnesses we're able to recover from them. They are not like diseases that now you're doomed for life. This is it for you. No, you will recover and you will move on. What will happen is after that, as you walk the journey, you'll be able to pick your risk. You'll be able to know your triggers so that they can help you manage your stresses. And when you see this is a high stressful, this is a trigger, then the patient is able to hold back and take a step back and actually analyze themselves. So yes, they are treatable and they recover. Okay, a good percentage of our patients actually recover. So it's not a death sentence, right? Yeah. And they can be prevented. That's the best part. In terms of you look at your environment. If you're in a high stress environment, then you work towards reducing that. We look at policy. We're trying to see if you can have policies that will get people to have good and positive mental health, so that we're not stressing our people too much. For example, in terms of environment, currently we are in the COVID-19 pandemic. People who never thought that they would ever experience any form of mental illness are currently experiencing some form of illnesses because of the environment we are in, because of the current pandemic. Okay? So we need to be able to handle the situation so that we prevent ourselves from getting the mental illnesses. Just because you are a high-risk person, just because in your family you have very many people with mental illness, it's not a must that you get the mental illness. I hope that I've been able to demystify some of the myths that you are commonly getting around mental illnesses. Thank you. Over to you, Anne.
Asante sana daktari, thank you very much. Actually, you've touched on very many myths, but there's a myth that is standing out, and it's even in the chat section. People link mental illness to witchcraft. And I'm asking, is it because we are Africans? Is it do Africans have a peculiarity that might make us more mental health prone to mental illness? And of course, many of us being Africans, we believe in witchcraft, we believe in curses. So, Dr., what would you say about that? Because it's common, it's appearing in every question.
Yes, so what has been shown is, number one, when you don't know much about something, you will tend to fear it, and you will tend to believe there's a special power that's bringing this, disease. I'll give you a real-time example. When COVID-19 was, when it was declared a pandemic, what is this COVID-19? There was so much fear around it. And there was this whole thing for, it has been sent, this disease has been sent to finish us because we are not listening. because we are not following what our, our heaven, there's the religious aspect to it. Okay? So we'll always have in life, we'll always have an explanation for something. And when you cannot explain it fully using science or what you can see, then you will blame the supernatural. And in Africa and in most areas, the supernatural aspect is witchcraft. Remember, in the European centuries, long time ago, how when they were coming up with the Bible and the whole Christianity in England and those areas, actually mental illness, when you're found with a mental illness, you are said to be satanic and you are killed. So the aspect of things you don't understand, the power of the supernatural has been there. It is not a new thing. Every time something new happens, some new disease comes across, there will always be an aspect, quote unquote, of the supernatural because we do not understand. Even when the Europeans came to Africa, they were dying from a weird disease that was giving them chills, that was making them have this bizarre behavior. They were not able to move. Guess what? Now it's called malaria. You understand? So the fact that they were not able to get what it is, they are not able to understand what this disease was, then it was witchcraft. Then it was a supernatural power. But then they sat down and said, no, let's see. Oh, they was around the water bodies. There's this insect that tends to transmit. It's very common in that area. If we spray and the insect, the parasite goes down, oh my God, the people are not dying. If we give them this disease, they recover. Ooh, they gave it the name malaria. And now nobody's bothered about malaria. If you're going to a malaria-prone area, you take your anti-malarials and life moves on. It's the same thing with mental illnesses. When you don't understand something, you tend to believe it's a supernatural power controlling it. So it's not a unique to African culture. It's something that has been there and it will be there. Yes.
Thank you. Thank you. You can hear me. I saw some of my unstable network here. Someone here is saying very interesting. Joel is asking. We hear that we are all mad. It's the degree that differs.
The degree that varies.
So what do you have to say about this? How true is this? Joel is asking.
So I think Anne has stepped out a bit. But yeah, about that statement, the way you can be told a statement many times, and then it becomes the truth because you've had it many times. So basically, as I said, mental illnesses, it's just how you're coping to your stresses. So it doesn't mean you're all mad. Gosh, then we would not be having a mental disorder, because for it to be a disorder, you have to be culturally, it has to be a culturally different thing from what your people believe in and what they see. Yes.
Thank you. I'm back. Can you hear me now?
Okay, cool. Yes, I can.
I actually think we need to mention the types of mental disorders, because when people talk of people being unkempt and dirty, that's the concept. Someone said that's what they think about. But there are mental disorders that we have the straight suits and the iron that pin smart. So maybe it's important to mention some of the disorders, because we are thinking of those extremes of people are being stripped naked, but yet in the street we have so many of us that are not okay. I think it's good that I mention a few of the things that can give us
mental disorders.
Sort of, yes.
Okay, so as I said, what we know is the 1%. Yeah, we know the psychotic illnesses. The patients who come, they are seeing things that nobody else is seeing. They are able to, hear things that nobody else is hearing. They cannot take care of themselves. They don't feel like talking to people. Those are the psychotic illnesses that are found in the mental disorder spectrum. We have the mood disorders. That's where, and what is a mood? You know how you're feeling, the state that you're in. So you have mood disorders where you have the bipolar mood disorders where patients are able to be very happy and elated, like they're on that other extreme. And then there's the sadness part. Okay. Then you also have the depressive disorders. I'm sure you've now, especially with the COVID, we've been able to see many patients or many clients who are going through different stages and forms of depression. Then you have the anxiety disorders. One of the commonest anxieties that disorders that you're seeing will be the post-traumatic stress disorder, especially with people who've the refugees, or also just patients who've gone through some form of trauma or physical abuse. You find that they'll always be recollecting things. So PTSD is one of the anxiety disorders. Another common anxiety disorder that people don't even know, it's just that we don't put it as a disorder because it's an episode. Have you met those people who cannot get into water bodies? They can't get into the water. You know, if they go to Mombasa, they would like to see the beach from a distance, but they can't get into it. When they go to Mombasa, they cannot get into the ferry. They have this fear that it will drown and they will lose their life. Yeah, and when they get there, they are just palpitating, they're sweating, you know. So some form of anxiety steps in. And when this is happening on a day-to-day basis, you cannot handle your work and all, then it becomes a disorder. But that anxiety feeling, actually, when you prolong it, then it becomes a disorder. So anxiety disorders also exist. We have personality disorders. We have old age disorders, you know, the old people, your grandmother, your shosh, who cannot remember you. All of a sudden, she only remembers things that she used to do when she was young. She believes she's like 18. You know, the dementia aspects that come with the old age, that's still a mental disorder. You have learning disabilities. We've commonly been, you know, in the recent years, we are seeing a lot of dyslexia, the learning disability, where you're not able to get like complete sentences and all. That's still a mental form of mental disorder. Substance use disorder, which is something currently we are in the young generation, we're seeing a rise in a peak. Substance use disorders is currently actually recognized as a mental illness, they are mental disorders because of the addiction component of it, the fact that you derive pleasure from something on a constant basis, and you have the negative impact of the substance use. And now substance use is actually one of the disorders in the mental illness spectrum. So the spectrum is big, just that people only know the 1%, which is the schizophrenia, the psychotic illnesses. Yeah.
Thank you very much. And let's stay with the substance abuse because there's a question here.
Mm-hmm.
How bad are substance-induced mental disorders, and can one get cured from them? I think let's stay with that question so that we get it out of the way.
Mm-hmm. So for substance use disorders, one you have to accept and admit. You have to admit that one, it's a large spectrum also because it depends on the substance that you're using, and it depends on what you're using it for. The reason why many people are still stuck in the cycle of addiction, in the cycle of substance use, is because we are not tackling the why. The why do you take your heroin? What are you running away from? The why is what we are not dealing with. Because we usually say nobody starts taking a substance to become addicted to it. It's a fact. You take it for something, either for curiosity, and then you kill the curiosity and you move on. You decide this is not what I want to do. But are you depressed because of something you went through when you were young? And that's what makes the substance use disorders a cycle. Because on its own, it's a cycle of addiction. Okay? It gives you pleasure. It does something for you. And that's why substance use disorders are looking like they're unmanageable. But in most people, when you are able to manage the why, when you're able to find out why are we using this thing, when you're able to deal with the why, then we can move on from that. I'll give you an example. If, for example, you're a teacher, right? You are expected to stand in front of people, students, and impact knowledge on them. All right? So you're here teaching. But guess what? Maybe you don't like standing in front of people. Maybe you're these people who are so reserved that when you're in front of people, you cannot pick it. You cannot be able to substantiate your knowledge. You feel like you're not good enough. So what do? You take a substance to reduce you to normal level, to calm you down. And you take the first day and you realize, Allah, now I'm able to articulate. I can teach my students better. I'm able to impact the knowledge. When they ask questions, I can answer. You're more confident. Guess what? This person will continue taking this substance so that he can continue teaching. All right? So with time, you'll find that this teacher becomes addicted to the substance. And you ask, when you take the patient to the rehabilitation centers and they're not finding out the why are you taking it? That why. Because maybe when he was young, he was told he cannot do anything good. But maybe, he was able to pass somehow. He got grades KCSE, he passed, he got maybe a B+, he did Bachelor of Education, he became a high school teacher, and now he's able to teach. But then he's still haunted by the fact that somebody somewhere told him he cannot be a good teacher. And so to be able to calm his nerves, he takes the alcohol. So you are here putting this patient on a 90-day program, but you're not solving the why. And so when he goes back, remember his work environment is the stressor, and you're not able to find out to build this person's confidence. So you still go back to drinking. And that's why we're finding a lot of issues with substance use disorder management. Most of our centers are not tackling the why. So if you're able to tackle the why, then it's good. We are good to go in most circumstances. Yes.
I like what you're saying, Daktari, because you find most people go, they get the treatment, but they don't solve the why. And that's how we collaborate, you as a psychiatrist and me as a psychologist. I know the people I can handle and there are those I can't. Especially mental illness, they walk into the clinic and you're like, this guy has no insights. So I have no business dealing with him. Let me send him to Dr. Priscilla. And that's how we work together, because you tell what is going on, and then I'll be able to ask him, how did you get here? So it's good to appreciate the two. We work together so that we're able to tackle the what and the where and the why. So let's talk about demonic possessions. There was a question up there that mental illness is as a result of demonic possessions. And then someone had mentioned there are these church leaders somewhere in Kisumu. They exorcise demons or they do deliverances. So what is your view about that?
Yeah, so for me, as I said earlier, there will always be the belief of the supernatural. In things we don't understand, there is always the supernatural belief. And in psychiatry, we always accept and admit that the religious belief and the spiritual power that comes in as a person, as a human being, your higher being. What is that you run to where you think you get your comfort from? And notice I'm saying higher being, and I'm not saying, the God that you believe in. I'm not saying Jesus Christ, because all of us believe in our own higher being. There are people who their higher being is a cat, and you cannot do anything about it, right? So there's the higher being part that comes in matters mental health and matters mental well-being. And the people I've seen in Madare and what I've been seeing is, yes, people start off with praying for them, like someone will start running around in the estate, start running around in the village, and they are picked and they're taken for prayers. But you see, we're not dealing with the why are they running around. We're dealing with what is it in the environment that makes them have this stressor. So we remove them from their home environment, where maybe that is where the stressor is. We take them to a church. So the environment is definitely different. And then, being African, we really pray a lot in our setup. So you put them in prayer, and maybe that is where their hope comes from. They believe there is this supernatural being who will make things okay for them. So while they're in that area, in that environment, they are good. But after X number of days, they are taken back to the home environment, which is the stressor. And this triggers another relapse. That is why we really want to work together as a sector. We want to incorporate all professionals in the sector. We want to work as a psychiatrist, a doctor. We want to work with the psychologist. We want to work with the religious leaders, because we cannot put away the fact that there's a spiritual aspect in each and every one of us. And you'll be looking for a spiritual part of you. And so we don't shun it. We don't like dismiss that part. But is it the only thing that is needed in the care of mental illnesses? The answer is no. It's a multi-sectoral collaboration to be able to make this patient, this person, become whole again.
Doctor, I like the fact that you're saying it's possible someone can have demonic possession and the others who are just mentally ill. And it's important for us, even as supporters or people take care of the people who are mentally unstable, to realize that there can be different ways. How did they get here? It's true, because I knew of a case of a student in Form 2 got demonically possessed. Of course, when he was admitted in Gertrude's hospital, the doctor came and said, this is not medical. There's something wrong about this child. So he told the mother, what do you believe in? Where is your higher being? And the mother says, we believe in God and we follow a particular church. Then she was told, go to church first. Have a discussion with the pastor, the priest, or the deliverers there. Because whatever it is, I've done all the medical tests and it's not there. And the child has a way of disappearing. He goes into some comatose state, then he comes back after a few hours. So he said, So it's important that we realize it is possible, but it's not for us to diagnose. The experts out there will say, this is medical, this is Pauline's client, this is Pastor so-and-so's client. So it's possible these things can be there, because there's a lot happening. It's good to realize you're in this world and a lot of things happen. Even witchcraft itself, we can't rule it out. I knew a case last month of someone who stole a neighbor's chicken in my village. And then I don't know what the neighbor did. So he started sounding like a chicken and he was quacking all over the village. So we are saying there is a mental illness or instability that can just a reason of the demons or the thefts and the witchcraft. But like I remember when I used to be trained, the teacher said, you don't have answers to everyone's issues. If they come and tell you, I think I've been bewitched, it's not for me to apply my value system and say, who bewitched you? No, ask them how, what makes them think they're bewitched? And ask them the next question is, what do you do when you're bewitched? Of course, I'll have done the assessment to see, is it really Pauline, Priscilla's client, or this guy has actually stolen his neighbor's chicken? So these things are there. We are Africans, yeah. What are you saying, Dr.?
I like the fact that the chicken thing was coming from your village. It can also come from my village. These are things we get from our villages. Unfortunately, we are known for those things that happen in the village. But yeah, you have to always take a history and find out, because it's a different spectrum. You have to always take a history and see really what's going on. You get the picture of what is really, really happening. Another thing that has been seen in most countries, and why do they say that witchcraft is something that's big for them, is you'll find the people who are high flyers in the family. The person who was doing so well, maybe they would say he was a bit, what is in English? Oh my God, he was a bit not straightforward when he was growing up, but he was a really good kid. He was going to class, he was performing well, like averagely, and then he went to high school, and then you hear someone say, and then he met friends who were taking substances, and that's where it went downhill. And they believe that an uncle somewhere did something wrong, because as a family they thought this is the person who would really save the family. And so they're like, why is this illness just targeting the high flyers in the society? But you see, sometimes mental illnesses start at a young age, when the patient is young, and nobody really sees it as a mental illness. That's now where when you take a history, you're able to know that from the beginning, this client had a problem. But people thought it was just his normal. He had an anger outburst. You'll be told, he was okay, it's just this week that he has a problem. But from before, he's been known to be very angry very fast. And when he's angry is when he does 1, 2, 3. So meaning this illness has been there, but no one is fixing it. But now that he was so angry and he committed assault, he now set the house on fire. that's when the uncle comes and the uncle has bewitched them. So you always need to find out from the history so that you don't term something as witchcraft, yet in real sense, it's a mental illness. So it's a thin line, and you always, like in my profession, you really have to check. And for someone who's practicing in our village, you have to be really sure. Just go and check what's happening from the villages, right? So that you don't put someone, to do funny things. And I'm seeing there's someone who's saying about eating grass. My friend, our villagers are very sick. You will eat a lot.
Doctor, I like the way you're talking about the thin line, because it's equally a thin line between mental illness and spirituality. We have seen some people when they start getting unwell, they become
religious,
very deeply religious. In fact, I have one I need to see next week. The brother called and said, your patient of last year, he has become very religious. He's preaching. Look for him. So I don't know, because it could be going the other way, because suddenly even the relatives are very worried. He has never read the Bible before. Now he's very busy. So there is that thin line of religiosity, spirituality, mental illness. And like you are saying, we need to run those tests, the assessments that will get us to know, were you this religious or something is not going right? So, and then I see Joel is asking. Joel is our neighbor from Uganda. I want to understand, as a matter of fact, some people with mental illness actually get violent. How do you deal with that fact? Then the second question, I have seen some
Pardon,
people,
I didn't get the first question.
Oh, the first one is, I want to understand,
Anne,
as a matter of fact, some people with mental illness, yes, you can't hear me?
No, I want, yeah, now we can get you. Maybe you can just have the mouthpiece closer, then we can get you now.
Mm-hmm. Can you hear me now?
Yeah.
Yes.
Okay. Joel wants to understand, as a matter of fact, some people with mental illness actually get violent. How do you deal with that? That is the first point he wants to know. I have seen some people proposing to take away one's sexual ability simply because they are mentally ill and they think they can rape someone. What is your take on that? So I'm hearing two questions. Is that question, I think, Dr. you tackled it, because he was asking, is there anything called demonic possession? Yeah, talk about violence and the sexual. There's something he's talking about, and I think that's also cultural.
So the violent aspect, as I said, only 5% in the American study of the patients are violent. But also another thing I'd like you to consider, when we are seeing our patients who are like having a psychotic episode, because of that, those are the people who are usually termed to be violent. Yeah, we said that's the percentage of people that we believe have mental illnesses, because that's what you see. So you usually are not understanding, and you want to make them do what you want. You want to force them, and nobody likes being forced. I mean, even you as a person, when you're forced, you might really love porridge, like wimpy porridge is like your thing. But when you're forced to take it, like those people who are forced to take wimpy porridge in high school as your only breakfast meal, now you're not forced. You feel like, I cannot take wimpy porridge again. Like you're done with that, simply because someone forced you to do something. Now imagine this is your day-to-day life.
Okay. Let me just get her back. In a few. You can just go on, Anne.
All right. Okay. So Joel, I hope that was addressed, that if you force someone to do something and you force him to go to a hospital, you force him to say things, and you force him to see things from your perspective, he's likely to get violent. The guy is back.
Sorry.
Daktari, unmute.
Okay, it sounds like Serebe is saying something. Joel?
No, I was responding to Madame Anne, where she was saying that because of coercion, there is a reaction always to that circumstance. So I'm saying I understand the situation. When you're coerced, there is a reaction always. And if it's the norm that daily you never understood, you might end up reacting daily to each and every situation. So you're taken to be violent. It actually you're repulsing to a reaction that is getting to your side.
Thank you, Joel. Daktari,
welcome.
karibu.
She's back.
Yeah, you know KPLC, yeah?
Yeah.
I'm telling you this country. Yes. So I'm leaving now.
Sorry.
So another reason why maybe our patients are violent, the 1% that will have a psychotic episode, is just try and imagine that you're in a room and then you see a snake. What will you do with that snake? Won't you beat it? Because you don't want the snake to bite you. So sometimes they are having visual hallucinations. They are seeing you as a snake or a lion. They will run away from you. You get? So they are, it's like they're seeing things that you are not seeing. So you're not understanding where this person is running away. Would you accept for a snake to hold your hand and tie it? You can't. You'll be beating that snake like senseless, right? So it's the same thing with patients with mental illnesses who are having a psychotic episode. You have to understand them and understand where they're coming from. And another thing, when they come to the hospital, like in Madari, where I work, yeah, they will be tied up, and they are violent towards everyone. But when they sit down and we are having a conversation, we are taking a history between the patient and the doctor. Somehow our patients are calm. It's in the language that we use to talk to them. And so the relatives think we are supernatural powers. We are talking to them. No, it's just the language that we are using to address our clients so that we can be able to understand them and they can tell us more. And they calm down. Most of them will calm down. And I'm talking about the 1%, the psychotic episodes. Not all, as we've agreed, the mental health disorders are broad spectrum and not all of them are violent. The second part of his question, I remember the first part was violence. The second part was matters family planning. So you'll find that some cultures, because of the fact that they believe the patients who are severely, is usually done for the patients who are severely mentally ill, not to all mental ill patients. The ones who have severe conditions are the ones where some families will decide to choose a permanent form of family planning so that they do not have many kids, so that they're not taken, the family doesn't have to bear the burden of taking care of the offsprings of these patients, because sometimes the patients are not able to make decisions on their own, and so they are taken advantage of. So you have patients who are, go through rape cases or sodomy, and for that reason, some cultures prefer just exercising some form of family planning in the clients. Am I saying it's a good thing? I think it's something that we need to discuss as a whole, as a community, because where they're coming from in terms of for the burden, it's not, when you look at it from their side, it's not a bad thing. But then again, you have to look at it from the patient's side and the patient's rights. So it's a discussion that is broad, and we have to really look at all sides to be able to make a decision. We can't just generalize, because it's very unfortunate that we have clients who are severely ill who actually get raped, and they can't tell anyone, so they end up getting pregnant, they end up getting diseases, they end up giving birth to children who unfortunately they cannot take care of, they cannot enjoy the joy of being mothers or being parents. So it's a very delicate place to be. Yeah.
Thank you, Doc. Someone is asking, I know there's a part of it you've tackled already, like do people recover from mental illness? That one you said yes. Is mental illness only for the poor? That's another myth. I haven't seen rich men in this situation.
In this situation, as we said, no. It's just that the people who are quote unquote rich, wealthy, the ones you think they have money, they will get treatment in those big hospitals that nobody can go. I mean, people are going to rehabs in South Africa, yet you and I will just go to Madare. So it's just a perception that people think only the poor people get sick. But yes, there's a high chance of having a mental illness in the low socioeconomic status because of our environment. The stressors are more. How many of us can go on holiday, my friend? Like you feel like you're going to work, you're too stressed, your boss is on your mind, you can't maybe get a job. How many of you can just afford go to Mombasa and sit and see the water and get the calming effect. That is you. But if you have the money, get on your own private jet, you've gone. So of course it will aid in how you handle your stresses in life. But does it mean the rich do not have diseases? No, they actually get sick and they get treated. Because as we said, 1 in 4. And the rich are also human beings. So they are also exposed to the risk of getting a mental illness in the course of their life. Yeah.
Wow, thank you, thank you. That is deep. But it depends on our socioeconomic status, and we get to know more of those who are low socioeconomic because you see them going to Mathare or Kenyatta Hospital, so we know, oh, but you don't know the guy who is flying to South Africa to get treatment for depression. Then someone else is saying, is mental illness genetic? Most families have been affected, and you find suicide running in that family tree. What do you have to say about it as a medic?
Yes, as I said, there's the psychosocial model. So yes, there is a percentage of the diseases. There's a percentage of clients or patients who will get it just because of the high risk. So the genetic part does play a role, but it's not it on its own. It doesn't mean just because your mother was depressed and ended up taking their life, dying from suicide, that even you must go through that. There will be now other things around. For example, as I give another example is breast cancer. We all know that, or general knowledge now, that there are some receptors that are, when you have them, you know, they do the test and they find these receptors, and then chances are you might get breast cancer. For example, we had this big, they're called these actresses, Angelina Jolie. I believe she went through a mastectomy where, you know, she removed her mammary gland because someone in her system, I think her aunt or mother, actually had breast cancer, and then they were checked and they found out that she had the receptors were present, and so to prevent her from getting it because she was at risk, she had the mastectomy. So it's the same thing with mental illnesses. The fact that somebody else in your family has the mental illness, it increases your risk of getting the disease, but it does not mean it is a must for you to get the disease. There will be other things in the environment, you know, where you're working, you as a person, how you handle issues that will now increase the risk more or further to getting an illness. Yeah.
Yeah, and they say it's our coping mechanisms. Usually you find in that family, the coping mechanisms could be poor. So you find they all tend to follow the same trait. And like Dr. is saying, it's not a must that if someone in your family had a mental disorder, that you'll also get it. Because it depends on who you are, even as a person. What is your resilience? What is your environment like? What is your view about life? So it's not a must that you get it. So there's a lot of hope in that. Someone is saying they like your sense of humor. You're giving very relatable examples.
You're welcome.
So they hope we are learning.
Yes, I hope you're also getting something other than the humor.
We are getting, I believe. There is a word here, I can't even read it. I hope it looks like it's a disorder. It's trichotillomania, a mental disorder in a 7-year-old.
I think that's the one where people pull out hair. So we need to find out why they're pulling out hair. So I'd recommend you go to hospital. First of all, find out the medical reason as to that. Maybe it's itchy, dry scalp or something. Then if you're able to rule out all the medical illnesses, then we'll now send to a psychiatrist or a psychologist, because there's always the why. Why are they pulling it out? Yeah, so we need to deal with that. So I'd actually recommend that you get seen by get seen by a doctor to actually give you the diagnosis. And then if it's actually a thing that's there and there's no medical condition, we will be roped in as mental health professionals to handle the disease. Thank you.
Actually, we are learning more, Daktari, because someone here is saying, wow, tackle the why. We really never think through this. Really great way to look at mental illness and other issues as well. We are learning.
Okay.
She Mingli says, what do you have to say about people who are not responsible for their actions, terming it as ill mental health? For instance, how do parents and society differentiate between laziness, defiance, and mere irresponsibility?
Now, that one, number one, environment. I believe your environment really speaks a lot about the kind of person that you will become. And so because there are people who are just plain lazy, and maybe it's how they were brought up, they were let to just lay around. For example, in those families where maybe you're like 10 children, like you're many children, and then you're the only child who is able to go to school and actually get something, everybody goes to school and scores 200 marks, but you, in KCP, you're able to score maybe 350. You become the star of the family. So you're not expected, quote unquote, to do the house duties or just self-care skills. So you find when you grow up, you become a lazy person. You're comfortable with that, you're comfortable with being lazy, around your environment. You don't have a mental illness. You're just plain lazy, and it's just how you are brought up. But then again, we cannot put a blanket. So that's why we come to hospital and get assessed. And our mental illnesses have how we make them a diagnosis. We have a duration. There's usually like how to explain? There's a set of things that you like a box that you must tick. We say, is there like 2 weeks of, for example, if it's depression, we say, okay, have you been feeling low, change of mood in a low status for most of the days in the 2-week period? We say tick, yes, we answer that. Then is there something that's was it different? So we always go through, there's a tick boxes that we tick for us to say this is a mental illness. Yeah. So there are people, of course, who will just hide behind it. But in the long run, you cannot lie that you have a mental illness. Either it will happen for real, and then you start saying, oh my God, I wasn't sick last year. This year is the one. But then you've been you've been lying to people, they won't know the difference. So it's good to just always get assessed, go get checked by a qualified mental health practitioner. A professional will be able to make the correct diagnosis.
It's also good to look at such in terms of what are we enabling as caregivers. Have a relative who decided him is sick because he used to get epilepsy when he was small, and then the mother and the father held, amjui na nini mgonjwa, for the sake of Joel. You don't know so and so is unwell. He decided to become nothing. He's now 40 years old because he's unwell. In fact, if I ask him anything, he says, you people, you don't know I'm unwell. I'm like, what? Actually, in the process, like you were saying, he actually became unwell. He became depressed because he turned 40 and nothing to show for it. So even we as caregivers, let us be very aware, what are we telling our children? What are we telling our sisters? Oh, he faints, so he's sick, he can't carry things. Like another day we had gone for some church function and there was a young man there, so there was something to carry. So I told him, help us carry this bag of rice and take it somewhere else. Then the mother quickly says, hey, this guy is sickly. He can't carry that rice. Then the guy shot out of the seat, took the rice and ran with it. So I was left following him behind. So what are we saying? So later I told the mother, don't say like that in his presence, because it actually puts him down. That he can't carry anything, he ran faster than everyone else. So what are we telling our people who we think are they're having mental challenges? So yes. So someone asked about grass. Of course, that is what we were talking about, the village. But the next, what do you comment about people being able to eat grass? Witchcraft is real? Question mark.
I think we already answered that about the people in the village.
Yeah, the village people. So, then someone says, yes, sure, most people have encountered when they become very religious, when they are depressed. So we were saying, yes, the very thin line. So let's go to the next question. Great presentation, Dr. Makau. I love the humorous way you present this topic. That's Jackie.
Thank you.
Then great point, Daktari. How you speak and approach the patients plays a very big part in how they respond to you as well. Yes, that one is where we were talking about violence. And you realize when someone you can find there's always someone they like talking to. Like if someone is mentally unstable and then they say, can I see so and so? Because that person talks to them differently. There's a way they make them appreciate their value as human beings. So let's practice to do that as caregivers, even as villagers or neighbors. Yes. Then we are getting a lot that Jackie. How long does it take for one to recover from a mental illness like depression? That's from Chelagat Hilda.
So I cannot give you a blanket statement on how long recovery takes. People are different, stressors are different, triggers are different. We usually give medication, especially with the depression, we will grade it. Is it mild, moderate, or severe? Moderate and severe cases, we start them on antidepressants. Mostly we give antidepressants intensively for 6 months, then we taper it down within a 3-year period. But that does not affect everyone. You can be depressed due to maybe, like now with the COVID-19 pandemic, people are losing jobs. Are you seeing, like in the media, we have a lot of slashes of jobs in the media fraternity as we speak. So that is a trigger, it's an event, and it might cause depression in some of them later on. And this, we've tackled well, will resolve depending on how we handle the situation. So are we saying that media personality A will get depression only just because they lost their jobs? No, there's always something about, as we said, the environment, the person themselves. All right, so that will also determine the amount of time it takes to recover. So if you're going through a process, if you're currently seeing a professional, or you feel like you're depressed, I'd actually ask you to seek help from any mental health professional. And then from there, we'll be able to grade your depression. Is it really there? Is it just a period of sadness? Is it mild, moderate, or severe? Do you need medications or not? And then now, how long will you be on the medication? And remember, with depression, as with most mental illnesses, we always rope in psychotherapy. So we'll have the psychologist on board, and then we work together. As I said, it's multi-sectoral. We work together. So as you work together through this journey of depression, you're able to know, you still need your medication, how long are you going to go with the therapy, and then we build up from there. Because in the therapy sessions, you're able to learn your coping mechanisms, you're able to learn how to handle different stressors in life. So we pick a lot during the sessions, and we're able to have a recovery plan. But as for an exact date, in mental illnesses management, we don't do exact. And actually, in most medical disorders, most medical disorders, we don't have exact, usually have time ranges. Yeah.
Thank you. Yeah, like Dr. is saying, it's your personal resilience as a person, your support system, your spirituality. There are so many factors that kick in to ensure that your recovery process is short and less painful. So someone else is saying there's a couple taking the same medication for psychosis, but the husband is no longer interested in sexual activities, and the wife is on the opposite side. Is there a relationship between the drugs, gender, and sex drive?
There's even a relationship between the illness and the sex drive. You know why most people, like the people who are manic, patients who are having a manic episode, that means they're in the bipolar, happy spectrum. They actually have a high libido. So they'll be busy, looking for someone. And then when you give them medication, it lowers their libido. All right. So yes, there's a relationship between the drugs that we take and the libido and the sex drive. So what we usually recommend is the couple needs to go back to their practitioners. Then we're able to give medication that is working for both of them. Kindly remember, they're human beings, and sexual intercourse is actually a human being, process, right? And you cannot take it away, right? And they're right anyway. So they see a mental health practitioner who will be able to alter their medication, change, get what works for both of them, so they can continue living their life. Yes.
Wow, there are so many accolades coming in, learning a lot, Daktari. Thank you from Musangi.
Thank you.
Is social media addiction in any way a form of mental illness?
As you said, social media addiction. Anything that we are saying addiction, that is giving you pleasure, that you're doing on day-to-day basis, that you're making it your primary goal, that is making you not work in your other environment, that is making you increase your hours, tolerance and dependability. Anything with all those things means you're getting hooked to it. And if you're getting hooked to something, it's a disorder. It's just that at the beginning, when they were starting, when they are grouping the disorders, the social media was not as big. It's become big in the last 10 years or so. So now, I'm sure in the next rollout of disorders that are coming up, it's going to be one of the big things that we are talking about. The same way with substance use. Before, it was not in the mental disorders category. But then you realize it gives you pleasure and it gives you all those things I was saying, the primacy, the tolerance. So then it's now a mental disorder. Social media is actually something we are seeing that is impacting our lives both positively and negatively, and it's causing different effects on people. And for that reason, social media disorder is going to come up. Even gambling, it was not as big before, but currently we are seeing that it's evolving, and we are having gambling disorder as one of the disorders in the mental illness spectrum. So yes.
Thank you. Jackie is saying how we refer to those with mental illness can either build or break one. Let us use the right language. And I remember one time when we were in college, you used to be told, don't say someone is depressed because you are labeling them. Say she has depression. We were told to learn to separate the person and the illness.
The disease.
Yeah, you can't, I think Dr. someone is saying the way we call people can either make or break them. Would you want to say something about that?
Yeah, I mean, language, the power of the tongue. That needs to be, you can't overemphasize it. That one is a given. I mean, if you, how would you feel, if someone just kept on saying, when you are Zimu, I mean, you have a mental, you're just mad, every single time, even if you're not. Can you imagine if you're having an argument with someone and then you're talking points, you're like, always do the dishes in the morning, don't leave them at the sink, and then they look at you and say, you're just mad. How do you feel? And you know yourself is not mad. Now imagine someone who's going through the process of getting better, and they're trying to, hold themselves together and trying to take their medication and trying to do what they're told in therapy. And then you come and tell them, you're just mad. It's really heartbreaking and it's not good. So we need to watch out our languages, what we use. Yeah, that language. We need to really check what we say.
Okay, so as we wait for Anne to come, I think there was the next question. We are coming to the end, guys. We were meant to take 1 hour strictly, but oh goodness, the session is just interesting, and of course, Priscilla is just awesome. So I think questions are coming in one by one, and we'll take them. And I hope we'll still keep time, but we have to answer all the questions coming from the public. Now there's okay. Someone says, Miriam Gitonga says, I am very grateful, Doc. You are tops. Then there's also one that says, Anne, we appreciate you hosting very well. Then we are glad, Miriam, what you are learning, elite. Okay. Great presentation, Daktari.
Lit.
Oh, lit. Oh, yeah. Okay, sawa. Generations. Amazing presentation, Daktari. How does schizophrenia? Okay, so this is a question. Amazing presentation, Daktari. How does schizophrenia anti-marriage? Is schizophrenia anti-marriage? Why?
You're asking psychotic illnesses and marriage.
Yes,
I believe maybe that's what they're saying.
Yeah, that's it.
Yeah. So just because you have a psychotic illness, which is one of the chronic mental illnesses, which is manageable by taking medication. Just because you have a psychotic illness does not mean you cannot do the other day-to-day activities like a normal human being living on this earth. If someone has a psychotic illness and they are taking their medication and they are controlled, why shouldn't they do their day-to-day activities? It's like telling them not to urinate in their breath. If they want to get married, let them get married, as long as they're able to make firm decisions and they disclose to their partners that, hey, I have a mental illness, I'm actually taking medication for the mental illness, and I'm on follow-up. And as you come into my life to become my life partner, I'd like you to help me in this journey. Ensure I take my drugs, ensure I'm able to know my triggers, my stressors, my day-to-day activities are okay. And when you notice something, because most of our patients who have supportive partners, the partners will notice a change in their behavior, and they're the ones who will be like, I think maybe if something is wrong, we need to do more reviews. But then now telling them not to get married, honestly, even you, don't force people. If they want to get married, love runs the world. Let them get married.
I totally agree with you, Priscilla. And also this takes us back to the point where we are trying to fight stigma, because now it looks like we're actually discriminating, and we are having so much stigma on a person who's suffering just because they're suffering from schizophrenia, that they can't get married and they can't marry. So that's one of the stigma that we actually need to get rid of. So they're also good people and they can make good husbands and wives. Isn't your doc?
Yes. Awesome.
Perfect. Perfect. So Anne, while you are away, we really apologize for Kenya Power and bundles and whatever it was, but you're welcome back. So we just handled one question.
Pretty sure I've lost the chat. So
oh goodness, yeah.
yeah.
Okay,
so go on.
Okay, so I'll go on to the next one, but I'm copying them right back to you so that you can handle the rest.
All right. All right.
The next one was is having a phobia for something a mental illness?
So phobias are under the group anxiety disorders. So yes, I'd want you to, if you have a phobia for something, kindly reach out to a psychologist who will help you go through the phobias and learn the condition that you put the phobias are putting you in. So they are anxiety disorders.
Okay, great. Mingyin says, please comment on comorbidities just briefly. How many disorders can one person pile up? I saw one diagnosed with trauma, autism, OCD, and ADHD. So how many disorders can one pile up?
So the beauty, I remember when I was starting med school, undergraduate, they said, patients don't read books. Books are written from patients' experience. Okay, so I can't tell you can't have you can only have one diagnosis. No, you can have different diagnoses depending on how you're presenting. Also, please remember there are people who are given diagnoses that are different depending on the person they're seeing, the practitioner they're seeing. So yes, you can have multiple diagnoses and take medication, either some are similar or not, to be able to handle the disease. Another thing with comorbidity is just because you have a mental illness does not mean you cannot have other diseases, e.g. diabetes, hypertension, depending on how you're living and the drugs that you're taking. There are some drugs that we give for the chronic mental illnesses that actually increase your metabolic state, so you're at a higher risk of getting, the depression, diabetes, and hypertensive disorders. So you can, just because you have a mental illness, you're not immune to other illnesses. The same way, just because you have a medical condition, you're not immune to mental illnesses. So everything, as a human being, you can have different variety disease spectrum going on in your body, depending on just who you are, your risk, your environment. So that's my take on comorbidity.
Now we are going to have it looks like the questions are almost coming to an end, like there's one more to go, but just amidst us is Jacqueline Allo, and she is a quality rights advocate. I tell you, you look at her and you know that she really cares about anyone else, and anything mentioning Madare touches her heart so much. So guys, and today it was also very interesting. We have stigma about Madare as a facility. Makau, you will comment on that before you leave, because anyone tells you anything, you say you need to go to Madare. Everything Madare. And I mean, guys, just looking at Dr. Priscilla, does she look Madare-ish to you? So I mean, guys, she's going to comment on that and the stigma. But just before that, I want to allow Jackie. There's a course that we've been telling guys to do so like almost all the time. It's called Quality Rights in Mental Health. And I just want Jackie to comment something briefly about that. Then we will go back to Dr. Makau, and then Anne can take it up, because it looks like the questions are done. Jackie, you're welcome.
Thank you very much, Aflin, and hi, everyone.
Hi.
So my name is Jacqueline Allo. I work with the Division of Mental Health I'm a mental health nurse and a quality rights coordinator, Kenya. So quality rights is a training, an initiative between the government and WHO, basically to promote human rights and mental health, an approach that is recovery-oriented and patient-centered. So it's a course that you can do online, get a free WHO certificate that can add to your CV in whatever it is, field it is that you want to pursue in health or mental health. The reason why we are doing quality rights majorly in the Ministry of Health is because there's a lot of stigma and a lot of ill treatment towards persons suffering with psychosocial, cognitive, and intellectual disabilities. That is the right word now to refer to patients with mental illness. So we are trying to change the language, we are trying to change the attitude, and we're also trying to change the perspective with which people refer to and relate to persons with the mental illness. So I think that's all, Aflin. So please join the course. I've shared the link with Aflin, so she'll share it with everybody and get to be champions of quality rights in mental health. Thank you.
Thank you very much, Jackie. Oh, I forgot to say I'm also a quality rights mental health advocate. So guys, you need to join the initiative so that anytime you see violence associated with a person suffering from a mental illness, then you know what the right thing is. Okay, back to you, Priscilla, then to Anne.
So mine was the stigma around mental illnesses. You know, you stigmatize someone or you discriminate someone based on something, on lack of awareness, on lack of knowledge of what it is that they're experiencing. And for that reason, one of the ways to reduce the stigma is to have awareness, is to talk about this mental illness. And there's a new term that Jackie has put across that you shall refer to instead of mental illness or a mental disorder. But we need to, if you learn something new, something good, you share it. But the same thing with mental illnesses, you share the information. Like now we've learned that one in 4 people in the course of their life is at a risk of getting a mental illness. So that means everybody, for those who are here in the chat, even at home, no one is immune. So the way you'd like to be treated at that time when you're going through a problem is the same way you treat these people with mental illnesses, the same way you treat our relatives, the same way you treat our friends. Be kind to them. Talk about it in a good way. Have more people know more about the illnesses. And once you remove the fear and you remove the lack of knowledge, then now you're able to understand our patients, and then you will not discriminate. You'll give them jobs. You'll make sure that the environments are stable so that you're not able to get relapsed. When they get relapsed, you support them. You use good language when you're talking to them. You understand that they have a right to life, have a right to make decisions, and you give them that space to grow. And that will really help us in terms of managing mental health conditions and challenges.
Thank you, Dr. I remember there was a question that had been posted earlier. I'm not sure that we've tackled it, of autism. Someone even referred it as a mental disorder. Maybe, Dr. you might want to talk about developmental disorders so that we are able to demystify.
Yeah, so there's child psychiatry, there's also child and adolescent psychiatry. So basically, in like layman's way of understanding what autism is, it's a childhood disorder, yes, where the child is not able to communicate using the language that we know as reading, writing, and body language. They have their own way of, let me give an example. You have children who you have the autistic children, they will communicate, maybe they take a phone, they'll write something, they have their own way of communicating. They're not using the language that we use, that we say, give me a cup, but they'll come hold your hands and directly towards that cup. So they've communicated, but they're not using the way our day-to-day. That's what makes them unique. They have difficulties with their social relationship, how they deal with people. They cannot sustain it. It's a persistent thing. They communicate in different ways. They don't even know, non-verbal, how you sit. The way your mother used to look at you and know you're going to be beaten. With children who are going through the autistic disorders, this is not something that they pick up. So you have to tell them verbally and be consistent on what you're saying for them to understand what message you're passing across. So autism, it's a lifelong thing. And I saw the other day that people who are saying you can be treated from it. What we are doing now is we are teaching our caregivers to be able to live with our patients positively, so that the patients themselves can get life skills to sustain themselves. They can be able to self-care. They can take a shower, dress up accordingly, know it's food time. And the beauty of the children who have the intellectual disabilities or childhood disorders, they usually have a line that they're really good at. Recently, I was watching a movie about the person who came up with IBM. It's something monetary, something about the computers. He actually had a mental disorder when he was young, but he was really good with numbers. And the caregivers supported him through that. So this brought out this big thing that we're doing, binary computers today. If it wasn't for that person who had good caregivers who supported him through his mental illness or through his mental condition, then would be a step back in terms of computers. So you can have a disease, the childhood spectrum, there's the ADHD, there's the autistic disorders that are coming up, but it does not mean that this patient will amount to nothing. Just support them, learn the skills, and I'm happy that these days we have very many groups that are helping our parents, our caregivers. So they join the subgroups and they are taught on different ways of handling patients who have autism or ADHD or any other childhood disorder that the patient will have.
Thank you. Because the question actually was asking, does it disappear in adulthood? Like, and you've answered it very well, that even in adulthood, it's there, only that it's managed.
Persistent.
Yeah, but it's well managed because maybe some are taught speech, others are taught social etiquette and all that. So thank you. Someone here is saying, before I wind up, please ask Daktari. You need to answer this question. It's urgent. Please, as you sum up, allow Daktari, how should one handle stress eating in this pandemic?
Yeah, step on our weighing scale. Anyway, so first, we have to agree that we are home. Most of the people who are not able to leave their houses to go to work and all, they're at home, or maybe the environment really requires you to take months to just forget what is happening in the environment. Number one, it's not a good coping mechanism. Kindly find other ways of coping. For example, have a good sleep routine, exercise, do your 30 minutes every day, talk to people. I mean, the beauty of having COVID-19 in 2019, 2020 is we have social media. So you can call people using the social media platforms. I mean, WhatsApp nowadays even has group conference calls, which is amazing. So you can communicate with other people, talk, read things from the correct sources. You're not going to be those people who do those forwards. Those ones for, if you don't send this, you're going to die. That's why if you send someone such a forward for COVID-19, it's not fair. They'll eat more. So you have to take care of yourself, have good self-care regime, so that you can prevent yourself. And the fact that you're stress eating and it's a bad coping mechanism, it's a negative coping mechanism, switch now. It's good. You're in the road to recovery. It means you've already identified the problem. So change it. Instead of, at that time, if you're really, really hungry, first start with water. Take a glass of water and drink. After 30 minutes, if you are really hungry, you will still be hungry, you will eat. But do other things to keep you busy, so that if you're used to 8, 10, 11, 12, 2, 4, 6, 8, no, you'll be like at 8, you'll be, because you have a good sleep routine, you'll be waking up on time, you take a shower, get ready. At 10 o'clock, you're busy doing something. If you can midday, you have your lunch. At 2, you're in a meeting, you're writing something, you're busy. At 4, you do your exercises. When you exercise, you get tired, you take a shower, you eat your dinner, bond with your system or your family members, wherever they are. By 10 o'clock, you've gone to sleep and the cycle continues. But if you're just going to be there, you're just seated over there, you have nothing to do, you don't plan your to-do list for the day, you're definitely going to eat more, you're going to get more stress, and it will impact your mental health negatively.
Thank you. Now that you say that, I remember I was talking to a relative yesterday, and she says her daughter decided to be baking. Now they've baked, they have eaten, they are fat. So she said, we've stopped baking because I asked her, what is happening? Why are you bored? That we stopped baking because we baked and ate what we baked. So on a daily basis. So yeah,
true.
And someone here is saying is overeating a disorder. Maybe quickly mention about food and disorders that come with it.
We have eating disorders also. I said mental illness are broad. Like the disorder is from here to heaven. There are so many disorders in there, and eating disorder is also one of them. But I'm not so quick to say like the COVID eating is an eating disorder, because as I said, there are boxes that you must tick for it to be a disorder. So just because you're eating now, and what really do we mean by your overeating? So eating disorders are present, but now for us to say it's a problem, you have to see the professional, and then we go through the checklist to see if you really fit that category of illnesses. Most of the people who are eating now, they don't think they're in eating disorder. They are just eating because they are not having things to do with their day-to-day. So keep yourself busy. And it helps for people who are weight conscious. Just take a weighing scale. Go buy one and then put it next to your bed. When you wake up in the morning, step on the scale. It will help you psychologically, but it might make you a bit unstable. So just get busy. Just get busy and take care of yourself. That way, you will manage your time well, and it will reduce the amount of time that you're using snacking during the day.
Oh, thank you. Jackie is saying, yes, let's eat less carbs, more vegetables, avoid sugar. It has worked well for some of us. That's what Jackie is recommending. So, Daktari, asante sana for your time, really. So, I think in summary, we can just say, what is our role as caregivers? Because we are either affected, they used to say you're either affected or infected. Yeah, we are affected by, we could be knowing someone who is unwell, who is having a mental challenges, mental illness, some which are full-blown, others are starting. So I think in our duty as caregivers or people in this forum, what is it that we can do? And I picked a few things, and I'm sure Daktari will say one or two things. I'll just mention like three. There's something they said, learn to listen carefully. You know, you can listen with your ears plus. You can start telling someone is not going the right way from the way they are talking, the way they're expressing themselves. That one for me spoke millions, because if we learn to listen what our people are saying, you start to pick those things that are off. You can hear something has started going off. And then also, we find support for them. It could be either through psychiatry or psychology. Like Daktari said, we work together. So let us be there. Let us be kind to the people we find who are having mental challenges. Let's not label them, because calling them names doesn't help. And then let's show interest. Like now, in this social media time, let's call each other more, find out who is going under. Like yesterday when I called, and then they say, oh, we used to bake, but we stopped because we became very, very fat after eating the cakes and the cookies and the cupcakes. So I asked them, why weren't you selling them to the neighbors? So we had a conversation around it. So let's reach out to one another. Let's find one another in this era, because we are here for some time. Thank you, Daktari. Maybe you can help us also know how to handle people that we find.
Yeah, usually my biggest thing is the language that we use, because you know your words, whatever you tell someone, even if they're not having a mental illness, words are really piercing, and words stay for long in somebody's mind, and words can cause people they can have a negative impact on people's mental health. So I usually am big on the language that we use on our patients, on relatives, friends who are going through various periods of their life in mental illnesses. Kindly just be kind to them. Use your words, choose your words. Use words that, even if you are going through something, would you like it? You know, make it you. Be compassionate, be empathic, but at the end of the day, mind your language and embrace our patients, embrace our people. You know, tell people the other side of mental illnesses. Just spread the news of positive mental health in each and every one of us. My parting shot is, yes, MITS will always be there about whatever illness that comes. especially when it's new and it's because of the fear and lack of knowledge. But once you have knowledge about something, the fear reduces and you're able to cope with whatever illness or whatever situation you're in. So it's good to always get knowledge on something, reduce the fear, and just help one another. Thank you.
Yes, and someone is thanking you. Thank you, Dr. Priscilla. You've definitely been awesome.
Thank you.
And also for me, I've been such a moderator. This was worth someone's time. I'm reading she means. I'm not saying.
Oh, but yes, you've done a good job. It makes it easier.
Oh, thank you. She says it was worth the afternoon. Good evening. That's from Shiming. She was happy to be here today. And I landed back to one Flynn. But there are many thanks coming through. I wish the session could go on there all day. I think Dr. made it very interesting that I've enjoyed being here myself because there's a lot to listen, the practical examples we can really relate to. Thank you so much. So back to you, Flynn.
Okay, great. So thank you very much, guys. I think this has been one of those sessions when we say we will take exactly 1 hour and then questions that just come in and you cannot resist to just take the questions. So for Dr. Makau, asante sana. You're always awesome. So we were very sure that having you in the session would be awesome. And thank you. I think guys have learned, and from the chat section, you can be certain that guys have picked a lot. And Anne Munyao, you never disappoint. I think you're just one awesome being, and we appreciate your presence, and thank you very much. So from the chat section also, there were people that were saying, Anne, good moderation and good presentation when you left, when KPLC did its thing. So thank you very much. And today I am seeing so many new faces, and I want to say you are all welcome. Do not miss next session. We are going to take 2 weeks break, just to put the house in order and also to get other questions on board. But after the 2 weeks, we are coming back strong with we are doing women's mental health. So postpartum depression and all that are coming in, and you do not want to miss that session. And especially for ladies in here, and also those who have mothers, sisters, and children and girls, you do not want to miss the session that is coming up. We will be discussing everything on a broad range. So from the chat section also, there have been requests that we should have another session on this. Priscilla, I hope you'll be in the next time that we come. And now that you're also part of the team, having you is going to be great. And also Anne, I hope that you do the moderation same time as she does her thing. So we'll have a session 2 for this same session. So thank you very much, guys, for joining. Harriet, Mandela, Lizzie, as usual, you never miss. Jackie from Ministry of Health representing Quality Rights Initiative. Guys have asked for the link. I've also shared it to the group with them. So I hope they'll start the course and they'll hit the mark. Chris Choto, as usual, you never miss. And all the rest, Gloria, Nyaboke, and Msangi, Shiming, we appreciate you for having stayed and having your concentration intact from beginning to the end. Thank you very much, Ruth, as secretary, for always being the opener. You do it greatly. So asante sana, we appreciate you. And thank you all, guys. See you in 2 weeks and do not miss. Thank you and have a good evening. Bye.
Thank you, Flynn. You've been awesome.
Bye, everyone.
Bye. We'll see you another day.
Oh yeah, see you next time.
Thank you so much, Anne.
All right, thanks.
Bye.
Bye.
All right.